Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, asthma. Dr. Elizabeth Matsui, a pediatrician and allergy and immunology researcher, talks to Stephanie Desmon about how environmental factors, from housing conditions to air pollution, play a key role in racial and ethnic disparities in asthma. She also discusses why asthma exacerbations don't just make it hard to be a kid, it can contribute to lifelong lung disease. Let's listen.
Elizabeth Matsui, thanks so much for joining me on Public Health on Call.
Well, thanks for having me. I'm excited to talk about asthma.
Let's start super easy. What is asthma?
Asthma, and I'm going to use a bit of a technical term but then explain it, is a disease whose root cause is inflammation in the lungs. And so what is inflammation? I tell my patients and their families that inflammation is essentially what is going on when you have a rash. So you can see the rash on your skin. It's red, it's maybe tender, it may be swollen, it could be itchy or painful. Asthma is a condition where there's inflammation that lines the airways. And then because of that inflammation, you can have narrowing of the airways. So the tubes you're breathing in and out of are smaller, and you may start coughing or may have trouble breathing. So there are a variety of ways, obviously, that you can address that inflammation, but fundamentally, that's what asthma is.
And how prevalent is it?
So across the U.S. in kids, the prevalence is about 8%.
Do we outgrow it?
That's a million-dollar question. Sometimes. So there are certainly changes in asthma severity throughout the course of someone's lifetime. And some kids will outgrow it, or it will go into remission and they may not need any medications, but they may be at risk, later on in life for having symptoms again.
So you've done an extensive research on asthma, and something I'd like to talk to you about today is, why do Black and Hispanic children have more asthma attacks than their white counterparts? What have you learned?
So I think it's become quite clear that there are environmental and contextual factors that are responsible for this, meaning that the air that you breathe, and again, you're breathing air, which may seem like it doesn't have anything in it, but there are actually all sorts of particles and that carry all sorts of environmental factors like pollution or allergens. You breathe them in, and then it triggers the inflammation and causes symptoms and emergency department visits. And so it is quite clear that there is not some genetic cause of high rates of asthma in Black and Hispanic populations, and that this really appears to be largely driven by environmental factors or contextual factors about how healthy the environments are where certain populations live.
And if I recall correctly from reading some of your papers, it has nothing to do with socioeconomic factors necessarily.
Well, they're closely tied together, and I think there's a history there that makes disentangling socioeconomic status from race and ethnicity complicated, but it is certainly feasible to do, which is that even when you account for socioeconomic status, Black and Hispanic kids and their families still are more likely to live in unhealthy, less healthy environments that include factors that contribute to asthma symptoms and attacks and emergency department visits.
I was reading one piece that you wrote about cockroach and mouse allergens. Talk to me about that versus cats and dogs and what role those might play.
So cockroaches and mice, we lump under an umbrella of pest infestation. And I think it is intuitive to most people that if there is housing that's in disrepair, often that's housing in a neighborhood where there's lots of housing in disrepair, that sets up the perfect conditions for pest infestation. And pest infestation then becomes endemic in those neighborhoods. With rare exceptions, people are not inviting pests into their home, whereas cats and dogs, almost all the time, people are inviting cats and dogs into their homes. And so pest infestation is really a hallmark of unhealthy, highly disadvantaged neighborhoods that have emerged through a history of housing discrimination and environmental racism and continued disinvestment in those neighborhoods.
So this isn't just a childhood issue, though, right? I mean, childhood asthma can lead to more problems down the road. Is that right?
Exactly. So I think everyone is familiar with a child having coughing or chest tightness or wheezing, having it interfere with their activity, their sleep, having to go to the emergency department. None of those are good. Those are bad. But what people may be less aware of is that having asthma in childhood is a major risk factor for lung disease in adulthood, and that having asthma in childhood also means that lung function, so how our lungs function essentially, matures or increases over time. And the poor kind of environmental conditions limit the development of lung growth or lung function growth. And so it sets kids up when they reach adulthood to start adulthood with already lower lung function than their peers who don't have asthma. Lots of medications that do a good job of controlling the symptoms that, day to day and preventing emergency department visits. We don't really have medicines that address this problem of the damage that's happening to a child's lungs over time that then sets them up for problems with their lungs in adulthood. But we do know that environment plays a role there. So there's a real opportunity to address this issue of childhood asthma being a major root cause of adult lung disease.
These sound like big structural issues, where people live, the air they breathe. How do we go about fixing this?
Wow, that's a big, complicated question.
I thought it might be, but do your best.
Yeah. So, as in many things in life, there's no one simple solution. There are probably, if we had the resources and the political will all aligned, we would package together a multi-pronged approach because it's clear that neighborhood really matters. So we know from one of our studies that kids who move from highly disadvantaged neighborhoods in Baltimore to much better resource neighborhoods in the Baltimore metropolitan area, they have huge improvements in their asthma symptoms and risk of having major flares or exacerbations. And in fact, those improvements are greater than what we see with just regular asthma medication. So we know neighborhood matters a lot. And so one approach to a multi-pronged approach is a housing policy approach, because these kids who moved through a housing mobility program, which is a program that administers housing vouchers but explicitly provides support to those families who want to move to better resource neighborhoods. But that doesn't mean we should ignore the neighborhoods that they are moving from. And so I think we also need place-based interventions. I think it is less clear exactly what that looks like, but certainly if there's infrastructure that promotes pest infestation and then other unhealthy factors like air pollution, those infrastructure issues need to be addressed. And this is all about the environment. I am not someone who thinks that the answer is either address the environment or address medications. We need all of that. And so we also know that kids are often under-medicated or under-treated, and they don't have well-controlled asthma, so they're continuing to have symptoms and have exacerbations. So we need to make sure that all kids with asthma have health insurance, they have access to high-quality health care, they have access to the medications that they're prescribed and can afford those medications, because we're not going to be able to address all of these environmental factors for all kids all in the next 6 months or what have you. So we really need that piece of the puzzle as well.
Could you talk a little more about that piece?
Yes. So we know overall that children are, and particularly Black and Hispanic children, have less well-controlled asthma, meaning they have more symptoms, they're having more emergency department visits, they're on lower doses of a daily preventive inhaler that we prescribe that has, I talk about it as cortisone cream for that rash that I mentioned earlier. This is like an inhaled version of that. So it's an inhaled corticosteroid. So we know that there are populations that are undertreated, and there are a whole variety of reasons as to why that might be. And it includes everything from they may be seeing their pediatrician who's covering many, many health conditions, and asthma is just one of them. And so the pediatrician says, "How's your child's asthma?" And the parent says, "Oh, it's great." But it turns out if you had more time to start delving into how often are the symptoms happening, and so you would find out that it wasn't great, and you might intensify the prescription, the medication that you prescribe. And then if a pediatrician has time to do that or refers the child to an asthma specialist who does have time to do that, the parent has to be able to have, first of all, be able to afford the visit, be able to afford the medication that's prescribed, be able to pick up the medication. And then another big challenge is adherence. And I think my patients are always surprised to hear that studies that look at medication adherence, that doctors and nurses on average take about 50% of the doses of a medication they're prescribed. And so if healthcare professionals only take about 50% of doses, imagine a parent, a mom who may be working 2 jobs and has other children or children with multiple health conditions and is living very much below a living wage, has got to keep on top of getting medication in twice a day, for example, for a child. So that's a challenge. So all along the way, that's a challenge. And then there are all sorts of other issues that come up where if you have health insurance, the insurer changes the formulary. So we had a huge problem that we don't need to go into this, where the what was approved and covered changed because of a drug company decision, and there was a gap in the ability to prescribe one of the major inhaled corticosteroids for a few months, and people have suggested that there was an increase in uncontrolled asthma and emergency department visits because of that. So parents are trying to navigate all of these complicated structural issues, as you mentioned.
So we have a few minutes left, and I'm wondering if what you see could be some shorter term solutions. How can we make steps toward controlling the situation?
So I think although Medicaid right now is at risk, I do think that is an incredibly important lever. I'm not a health policy expert. In increasing insurance coverage through Medicaid and increasing referrals to asthma specialists, I think are going to be key on the medication side of things. On the environment side of things, there are housing mobility programs that are scattered throughout the country. They are not yet embedded as sort of a standard part of housing policy across the country, but there is now strong evidence that they work to improve asthma, and so there's a lane there. There is absolutely hope and optimism, and it may not happen tomorrow, but that we can, and the policy experts can scale this concept of housing mobility across the country, and I think that would have a major impact.
Elizabeth Matsui, thank you so much for joining me.
Thank you for having me. It's been a pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.